It's 6:30, so we'll start.
Yes, ma'am.
So good morning, everyone. This is again another Monday when we are going to see and witness a very simple lecture where you will definitely learn the basics and how to read X-ray when it comes in day-to-day practice. About Dr. Thulkar. Dr. Thulkar is basically a professor of radiology, oncoradiology, and head of the department of oncoradiology at IRCH AIMS. Before I read his CV, I just want to say one thing, that in various platforms, wherever I get an opportunity, I say a very personal thing about Dr. Thulkar, that Dr. Thulkar is an excellent human being. And, I always keep saying this, that when God was making human being, I think he made Dr. Thulkar alone sitting in a very peaceful time, because he's such an extraordinary human being that whenever you will meet him, you will find him an extraordinary person. And whatever progress we have done in terms of oncoradiology or radiology intervention, I think it is all because of support of Dr. Thulkar. Dr. Thulkar is an expert in oncoradiology. Basically, he's very expert in gynae-oncology and prostate imaging and non-vascular intervention radiology. He has got almost more than 200 publications and 10 interdepartmental projects. He's co-guide of n number of residents, and our residents also. He is guiding a few of our MD palliative medicine students. Also, he is guiding if their thesis is interdisciplinary. So before I keep on, otherwise I will keep on speaking about Dr. Thulkar. Dr. Thulkar, I request you. And now one more thing I want to say, Dr. Thulkar was down with again the COVID, same which everybody is getting in these days. Maybe he must be still feeling weak, but he has accepted our request, and he is going to deliver. And you will witness a simple teaching of X-ray, and the way you will learn, you will really feel confident after this lecture. Thank you very much, Dr. Thulkar. Please go ahead.
Thank you so much, ma'am. Thank you for the kind introduction. Now I am going to share my screen, and this is a very basic lecture about chest X-ray or MBBS level, and that's how I prepared it. And so it's basically revisiting what we already know, most of us already know.
9 hours 7.
So why imaging in palliative care is required? So now we know that palliative care has there is a lot of developments, and several new treatment options are now available in modern palliative care. These may include medical intervention, surgical procedures, and now also some interventional radiological procedures. And so use any or multiple of these treatment options. Imaging information may be useful for selection or cancellation of any planned treatment modality, which is based on this imaging information. It may also help us to plan the discharge of the patient, because imaging in palliative care mostly is performed in hospital setting when patient is admitted in palliative care. And depending on the imaging findings, which we get the new information, that may prompt us to have discussion with the family, and with this information we can take the informed and better decisions, so that it will help for that purpose also. So as I said, this imaging is mostly obtained in inpatient settings, and the commonest investigation imaging studies performed are the X-rays, which may include standard X-rays in the X-ray department or bedside portable X-ray, and also the ultrasound examination, which is mostly bedside in palliative care setting. Higher imaging studies like CT scan, MRI are rarely required for palliative care purpose, because most of these patients, if they are from cancer, they might be already having these investigations available with you. And so it is generally not required for just for palliative purpose, except when you are planning some major interventions, it may occasionally require. So basic investigation would be X-rays and ultrasound, and they are quite simple. So, imaging also has some, is not totally advantageous. It has some disadvantages or limitations also. So in this particular setting of palliative care, when patient is very sick and terminally ill, and not much treatment options are available, so harm versus benefit consideration is important, because imaging frequently involves transfer and positioning of the patient, which can be quite comfortable for X-rays or CT scan, ultrasound. You need different type of position, and very sick and metastatic patient pain with a lot of pain, they may find it uncomfortable position. There may be also if patient is having catheters or tubes for feeding purpose or for medication purpose. So during this if maneuvering or positioning is unsupervised, there is a risk of dislodgement of this catheter. And also there are even you are doing image guided interventions, there are complications. These interventions are very small or large complications that should also be kept in mind. And based on these pictures, you should judge whether this imaging is particularly required or not. And find it is worthwhile to find and try to locate if there is any recent images already done and which is available. So if you find that, then this new imaging sometimes can be avoided altogether. Now my talk is about chest X-ray. And chest X-ray for any purpose, palliative or non-palliative, is the single most commonly performed radiological investigation. It's like just a hemogram, and it is the cornerstone of chest diseases. But for other diseases also, chest X-ray is generally part of the imaging workup or clinical workup. And so it has become a part of routine patient care, whether indoor or outdoor, palliative or curative. Now, before going to the basics of chest X-ray, there are some technical aspects which I want to highlight here. Nowadays, X-rays are done with the high kV technique, kilo voltage. Previously, with the machine, there were two options available: low kilovolt. That is basically tells the energy of the X-ray or quantum of the X-ray. So high kV X-rays are done, which gives good penetration. Contrast is slightly less, but you can see from behind the diaphragm, behind the mediastinal. So very high kV are used. And because high energy is delivered, total requirement of the quantum of energy requirement is same. So exposure time is short, and it is in few milliseconds. So even if patient taking a breath or respirating, it's not moving, you get very static picture without any motion blur because of this very short exposure time. And nowadays there is a digital acquisition. So instead of getting directly on the film, you get the digital image on the computer monitor, which you can print, you may not print, you can transmit on CD, pen drive, anywhere. So this digital is very important. It is important to remember that digital X-ray and conventional X-ray, they have no difference in terms of the diagnostic accuracy. So that should be kept in mind. Digital X-ray is not necessarily better. This high kV X-rays and short exposure time is generally possible with the big X-ray machine, which is the fixed machine in the radiology department. Portable machines, they do not deliver so much of the exposure, so they give the traditional type of exposure time and energy. Now for PA chest X-ray, it's an erect view. Generally patient is facing the cassette or X-ray detector, and tube X-ray source is behind the patient, and patient X-ray source and patient, the distance is 6 feet. This long distance, about 180 centimeters, it reduces the magnification of heart. So that is important for that. And also during PFU, the patient's positions, this rotation of the shoulders and external abduction of the arms is made by a technician in such a way that the arms, scapulae, they are retracted outside the skull pit, lung pit, and you get the clear picture. But this is again standard PA erect film. Inspiration, the exposure is taken at the end of full inspiration. Patient is asked to take the deep breath so that lungs are expanded, and then exposure is made. So how to judge that? When there is a good properly performed X-ray with the full inspiration, posterior part, these are the big ribs are seen prominent. These are the posterior parts of the ribs. At least 10th rib should be seen, or this oblique low density is the anterior part of the. This is at least 6 to 7 ribs should be seen. Then we consider that X-ray has been taken with the proper full inspiration, so lungs are properly seen. Now, it is important to have an inspiratory film, because that includes this causes complete lung visualization. And if there is film is expiratory, the lung visualization will be incomplete. These two X-ray films you see here, these are the same patient. This is done without full inspiration, and this is properly done lower X-ray with proper inspiration. So what you can see that when this expiratory film, you see the heart is look much bigger than this actually is. Mediastinal also looks wide as compared to the normal here. And also there is, you can see in the lower part of lung bases, particularly left lower side, there is crowding of the vessel because diaphragm is up, and this looks like there is some consolidation pneumonic patch. But when this complete inspiration is done, properly done, the lungs are well seen, diaphragms, heart is all right, and there is no infection actually. There is no consolidation in lower lobe. So this type of artifacts can be seen if patient is not taking properly deep inspiration. Also, you can see that these CP angles are not well seen here. They are blurred. So small pleural effusion can also be easily missed if the film is not with the full inspiration. Now rotation is important. Patient should be standing absolutely perpendicular to the X-ray beam. So this patient's X-ray, you can see how do we calculate in the perfectly mid-sagittal plane. You can see this spinous processes here, and if there is no rotation, this spinous process should be some the equal distance from the medial end of clavicles. So both lungs are equally opaque. Here the patient has rotated. Now you can see patient is not standing properly. This clavicle has come left sided very close to the spine. So what happened? This left side of the lung is more opaque, right side of the lung is more loosened. But this is just because of the rotation. Size of the lung will also, and this will create the mimic the pathology, but it is not. So proper rotation is very important to obtain proper imaging information. Now AP view, the anterior posterior view, generally they are done in the portable film bedside, in the wards or ICU, and because patients are mostly sick, they are supine. And also you cannot have the very small machine, low power. So the distance between the X-ray source and patient is small. And because of this is poor quality. You cannot have the perfect positioning, absolutely no angulations. And because patient is lying down, diaphragm moves up. There is also overlapping of the scapulae and the arms here. And there is also magnification. And so lungs are not completely properly evaluated. And there is a motion blur because the small power machine to deliver that much energy, they take a longer time. So in that patient, this patient is taking breather movement. So there can be some movement blur. So there are a lot of limitations on HP chest X-ray. So one we have to remember here that portable based X-ray is not exactly the same as a standard chest X-ray. As far as possible to have proper information, you should always try to get standard X-ray PA machine, a PA view on the standard X-ray machine. Portable X-ray only when it is not possible. So it will, and we should understand that it will not give that much information which a standard X-ray film can give. Now the interpretation of chest X-ray radiograph, and here we should have a proper knowledge of radioanatomy, and we should also correlate it with the history and presentation of the patient, and also correlate with the other investigation lab, etc., which is available. Now it is the technique to analyze radiograph in the systematic pattern. To start from the periphery, come to a center, or just go in the reverse direction. So there is systemic search is definitely is sometimes of this pattern is followed, like you go the clinical information, the technical centering, positioning you check, then trachea, heart, lungs. But this is just a one broad guideline. One is free to have his or her own pattern, and every time one should try to stick to that pattern and analyze the X-ray. Now first we'll come to the lung fields. That is the most major part which chest X-ray is done. So lungs are anatomically divided by interlobar fissure or major fissures and into upper and lower lobe. There is a minor fissure which divide upper lobe into further middle and middle lobe, and this minor fissure is on the right side only. So we have the right side upper, middle and lower lobes, and left side only upper and lower lobes. Now this is actually the orientation. We see the laterally patient, this is lateral view schematic diagram. From T4 you draw a line, there is a fissure which goes to anterior costophrenic angle, and on the right side also there is from this hilum to straight line anteriorly. So these three lobes are there, upper lobe, lower lobe and on the right side, this is the middle lobe. But this is on PA film is difficult. You can see, if you see from the anterior posteriorly, there is a lot of overlap. Now, this is the chest X-ray normal X-ray view, and you can see here, these both lung pits are clearly seen. So, approximate location, this is the approximate location of the upper lobe. So, it is shaded in the green. So, this is occupying more than half of the lung. This is the area occupied by the lower lobe, the yellow one. And this is the area, the pink, occupied with the middle lobe. So, you see there is a lot of overlap. So, for example, if I see there is this, my pointer is standing here, and there is some nodular pathology seen here. So, it can be anywhere. It can be upper lobe, it can be lower lobe, it can be middle lobe. So, it is difficult to perfectly describe or locate the anatomy in particular lobe. So, what's happened next base? So, instead of describing it lobe, because that we cannot determine on chest X-ray, for description purpose, the X-ray fields are divided into, lung field divided into three, approximately 3 equal zones. This is called upper, mid, and lower zone. And for this purpose, a line is, imaginary line is drawn from the anterior end of second rib. This is one line, and this is anterior end of fourth rib. There is another line. So it will divide the line into 3 parts. So you locate the anatomy approximately into and describe instead of lobe as a zone, upper zone, mid zone, and lower zone. Now, pulmonary airways, the trachea and main bronchi are seen, but intrapulmonary bronchi and bronchioles are not seen unless they are end on or thickened because of disease like bronchiectasis, etc. And they may be also be visible if they are surrounded by airless lung parenchyma, because air may contain air. So surrounding lung parenchyma is consolidation. Then it will be seen, like you can see some lucencies here, linear, and some dot-like. So these are small bronchi which are air-filled. So that's why they are looking black. And this is called air bronchogram. But this is in only in abnormal lung. Normal size, you don't see that. Now, lung fields are generally divided into hilar, perihilar area, the mid lung, and peripheral. So you can see hilar area, you can see vessels very nicely, clearly. And but the arteries and veins, they look same. They cannot be distinguished. They gradually taper. So you will see some part of the vascularity in the mid lung, but peripheral third lung, you hardly see any vessels, and that should be the normal appearance. If you see too many vessels outside in third part, the lateral most part, then it indicates hypervascularity. On PA film, because the patient is standing and there is gravity dependent, you can see upper lobe vessels are narrower than the lower lobe vessels because of gravity, these veins, etc., they distend more. And this is the normal finding. This is not increased bronchovascular markings. Now, Silhouette side is important to locate the pathology. It says that intrapulmonary abnormality, if it is in contact with the heart or diaphragm or aorta or anything, direct contact, so then these two pathology will not be separately seen. They will be merging which together. However, if they are overlapping, just overlapping, there is normal air in between these two. Even though they will be seen touching each other, their individual borders will be well seen. So even with the overlap. So how this help? This will help you to locate the pathology in relation with some solid structure. So we will see how it looks like in some situation. Now the Hila. Hila, these contents are pulmonary artery, pulmonary vein, main bronchi, and lymph nodes. And left hilum is generally a little higher than the right, about 2 centimeters. So that is normal anatomy. The hilum, when we evaluate their density and size. They should have symmetric density and symmetric size, and their lateral margin is straight or concave. Abnormal hilum is unequal size and unequal density. You can see that this hilum is little loosened, but this is little dense. Size is almost same, but this is actually because of the lymph node, as you can see in the PET scan. Just behind the hilum, there is lymph node. So it is not clearly seen, but it is seen as increased density on the chest X-ray. This is the example of sarcoidosis. Here you can see bilateral bulging and convex contours, very dense hilum. So this is the bilateral hilar lymphadenopathy, example of hilar lymphadenopathy. Now hilum or less side. If we see the hilar mass can be because of the vessel itself which is enlarged, or it can be separate mass overlapping the vessel. So if the vessels are seen through it, that indicates it is not vascular enlargement. It is a separate lymph node or some mass. So that is called hilum overlay sign to differentiate between vascular mass versus non-vascular mass. It is also this is example of old lung. As we age, there is osteoporosis, some deformity of the lung. So the shape of the lung changes, and there may be some narrowing or widening, crowding of the rib, which is perfectly normal. And you can also see the lung pills. There will be increased bronchovascular margin because of the fibrosis around the vessels and bronchi. But this type of appearance, again, for any old age person, this is normal. Now we should come. Again, we can have sometime on X-ray sequelae of old infection, like you can see thin fibrotic bands like this, or you can see these calcified lymph nodes, mediastinum. So these are the sequelae of old infection, mostly subclinical infection, which we commonly have in our country. So if we see these type of findings, it is just of no significance and can easily be ignored. Now we come some tumors. So lung cancer is the most important tumor, and they can have typical appearance or non-typical appearance, atypical. So the most common will be the mass lesion, lung cancer, and mass can be central like a hilar mass, or it can be peripheral irregular mass like this. So this is easy to diagnose. It can also be seen as a cavity, but cavity can also be seen on infection. So how to differentiate? It generally has a thick wall, and it is eccentric. Cavitation lucency is not in the center. One part, thin part of the wall of cavity, other part will be very thick because it is developing into, this is a CT scan, for example, for same purpose it is seen for. So there is various thickness of the cavity enhancement and irregular margin of the cavity. So that indicates malignant cavity. And you can sometimes also see as a collapse of the lung. You don't directly see the mass on chest X-ray. You will have to do CT scan. So what we will see, there is the upper low opacity, which is quite homogeneous, and there is bulge of the hilum. So it gives this reverse S type of sign. This is called golden S sign. That indicates that there is a hilar mass causing the collapse, which is better seen on CT scan. Now, atypical presentation can also be there, where you don't have direct evidence of the mass lesion or cancer, but there are other signs by which you suspect there is a lung cancer. One is indicates pneumonia, which is simple like a pneumonia, but which is non-resolving or atypical and stable for very long duration, non-progressing, not decreasing, not responding to antibiotic. This is also one of the presentation, and when you CT scan a bronchoscopy, you actually detect the cancer. This is a case of collapse of the lung. You can see this is the diaphragm is raised. Actually, this is a very straight margin, and this part of lung is more loosened. This is overexpanded upper lobe and collapsed lower lobe, but you don't see the mass on chest X-ray because it's the central small mass causing the bronchial obstruction. So this is the one of the atypical finding. You can also have the chest lung cancer, which is anatomically and pathologically just like a consolidation. It's called lipidic pattern type of lung cancer, or it's also known as bronchoalveolar cell carcinoma. It's adenocarcinoma basically. Here the tumor grows with the alveolar filling of the airspace and airway without actual invasion. So it's just like a pneumonia. So it gives the nodular consolidation, dense consolidation like this with air bronchogram. This is the chest X-ray, we can see consolidation. And we can also see on CT scan like a pneumonia. So this is actually a lung cancer. You can also see collapse, which may be complete collapse of the lung because central mass, and there is a heart, mediastinum has moved to left side, and there is a crowding of the ribs as compared to the other side here. Or there can be partial collapse. This is the hilar mass here, and this is the lower lobe collapse here, which means overlapping the artery. So partial or complete collapse. This is the indirect sign. Pancreas tumor is basically a lung cancer of any histology, but it invades the apical part of the lung, including chest wall, and extends to shoulder, the stellate ganglion, and brachial plexus. So it's a clinical presentation. So that's how it looks like. This upper lobe pleural thickening, and there is rib narrowed and eroding of the rib as compared to the other side. It's better seen on CT scan like mass eroding the vertebra and the upper rib. And here on MRI, you can also see the mass encasing the brachial plexus and subclavian artery. Carcinoids are the small, smooth endobronchial lesion. They generally present as a solitary pulmonary nodule, and they have calcification. This is the cancer which can have calcification. Otherwise, so this is the one small carcinoid air trapping. So this part is more loosened because there is air is trapped inside. There is emphysematosis. You can also have collapse or the tumor here with the mucoid infection in the dilated bronchus fluid field. And here you can see main bronchus, and there is this white content inside. This is a typical presentation of lung carcinoid. Small cell lung cancer is most aggressive lung cancer, and majority up to 70 to 80% patients, they already have metastasis at presentation. And on imaging or chest X-ray, it generally presents as a not as a lung mass, but as an extensive hilar and mediastinal lymphadenopathy, and often with SVC syndrome. So lung cancer primary is usually very small, but sometimes not seen also, but you see mediastinal widening, large bilateral mediastinal widening. And this CT scan, you can see this large mediastinal mass bilateral, and this is the thrombosis in the superior vena cava. So this is the typical presentation of small cell lung cancer. Now, lung metastasis is the important topic for cancer patient. And as we know, lung is the most common site of metastasis and generally seen as pulmonary nodules, which may be single or multiple, small and large. So there is no primary specific appearance, but some imaging features are more common with certain types of cancer. Like most common appearance will be this cannonball, small nodules or large nodules like this. And they can be seen in anything, but more common with the sarcomas, germ cell tumors, colon, and melanoma. The small miliary dense opacities, they can be seen with the thyroid cancer, kidney cancer, or melanoma, and rarely calcified. The dense calcification, small, big or small calcified nodules, they can be seen with the osteosarcoma, chondrosarcoma, pancreas, and ovary. Lung metastasis can also have cavitatory. You can see big masses. The air fluid level and cavities in many of them. These are generally seen in squamous cell carcinoma or transitional carcinoma. But any metastasis after chemotherapeutic treatment, they can develop cavitation. There may be hemorrhagic metastasis. How do we identify? There is nodule, but surrounding that there is hemorrhage. So they appear ill-defined. Pneumonia-like appearance around the nodules, that indicates hemorrhages, and that is generally seen in aggressive tumors like cholangiocarcinoma, choriocarcinoma, or angiosarcoma. Lymphangitis carcinomatosis is typical spread. Here the retrograde filling of the lymphatics and obstruction of the lymphatics. So there is lymphedema of the lung. Patient generally present with intractable dyspnea, and it is difficult to diagnose. Mostly seen in the breast, lung, GIT, or pancreas, and this is present as a because of thickened lymphatics, increased reticular markings, maybe unilateral or bilateral. So on X-ray, you just see the increased dense bronchoscopal marking. It also has nodules, but they are generally seen with CT scan like this. You can see as compared to the normal side of lung, the thickening of the bronchovascular markings because lymphatic obstruction, and also see nodules inside. Now we come to the chest infection. Pneumonia, there can be bacterial pneumonia, it can be lobar pneumonia involving complete lobe like this. So this is the example of left, right, lower lobe pneumonia, lobar consolidation. And this is the upper lobe pneumonia limited by the transverse fissure. So because this is only the upper lobe. So this is most commonly seen in the simple bacterial pneumonia. When this pneumonic spread after patient aspirate and they spread through the airway with the inspiration different part, you can get a patchy pneumonia like this. Here, 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 small and large. So instead of lobar, we will call it as a bronchopneumonia. So this is the airway spread. It can also go into septicemia and spread through the blood. So small emboli will get lodged into the lungs, and then they develop like a small pneumonia. And mostly they are seen as the nodules, which are small cavitation like this. And they will be all of same size, appear at the same time, unlike metastasis. So these are, and patient will be patchy. So these are septic emboli. This is also type of pneumonia. Lung abscess, they are rare nowadays, but they are seen as single big consolidation with thick walled cavity, and it may also have air fluid level because some part is expectorated. Tuberculosis is important infection in our country. So mostly they will be seen as the infiltrates. Infiltrates are nothing but the patchy small pneumonia, and mostly favored site will be the upper lobes here. So these are typical findings. These may have cavitation or calcification. The other presentation will be mediastinal lymphadenopathy, particularly in the young or children age group, where we see the bilateral hilar or mediastinal whitening. This is a typical case in community setting which we observe in immunocompetent bilateral upper lobe infiltrates. They are also seen in lower lobe, but they're predominantly in the upper lobe. And you can see multiple cavities here. This is the cavity, this cavity, and also small cavity here. So upper lobe infiltrates with cavitation is a diagnostic, and you practically don't need any other investigation. So here also again another case, multiple areas of infiltrates radiating towards hilum and thick walled cavities. Also better seen on CT scan. Pneumonia containing cavitation. Miliary tuberculosis is when there is small dots, the hematogenous spread of this like this emboli, and you see small dots like this, but dots should be very small, just like a pinhead. Anything bigger than that will be called bronchopneumonia. So this miliary tuberculosis is very typical X-ray finding. Now fungal infection is common in cancer setting. They also look like bronchopneumonia, but they will have nodular appearance, multiple nodule-like area, and surrounding that there will be ill-defined outline. This is because of the hemorrhage around that. This is called ground glass opacities, which is difficult to appreciate on chest X-ray, but you can see on CT scan this consolidation, and around that there is faint increased density here, like you can see. These are because of the hemorrhages. So you see ground glass opacities around the nodule, and in a proper setting, you diagnose it as a fungal pneumonia. Now the COVID infection is also common. They are seen as ground glass opacities. Ground glass opacities, matlab, they basically increase the density, which is beginning of the consolidation. It's a low density, so you can still see vessels or ribs inside that. When dense consolidation, you don't see anything. So basically, ground glass opacity is nothing but the low density consolidation. So they are initially seen as a low density consolidation, mostly in the peripheral part of the lungs, subpleural area. And with the progression, they can also have some fibrosis when they heal like a fibrosis like this. It can have various appearance, and in proper clinical setting, X-ray is used. Now, this pulmonary opacity can be because of the pulmonary edema. This is the early edema where this fluid accumulates in the perihilar area. So you see this increased pneumonia-like thing, blurring the vessels, etc., in perihilar area. This is called bat's wing appearance. So this perihilar increased density. In severe cases, for example, ARDS, when the complete lung is, there is a lot of physical destruction and edema everywhere, you see complete ground glass opacities in both lungs. And this is because of ARDS or any severe form of edema will have that type of appearance. Again, another case example, bat's wing area appearance, ground glass opacity, and here it has spread everywhere on the both sides. Aspiration can occur, and because of these contents are aspiration frequently gastric content acid, so it also causes chemical reaction apart from the opacity, and this chemical irritation reaction also causes inflammation and edema. So it also basically type of pulmonary edema, but aspiration will mostly in the dependent part in the central, depending on facial position. So we get edema like things on both sides, which is sudden in appearance. So this ARDS, which is mostly peripheral density, and aspiration will be in the central part if the patient has a proper history and features like that. Now anything filling the airspace will be opaque. So pulmonary hemorrhage is also, it looks like a consolidation, but in proper clinical setting, like patient has low platelet count, etc. So they are seen as a bilateral but asymmetric ground glass opacities or consolidation like this. And they peripheral sparing, they do not touch the pleura or mediastinum mostly. And the hallmark is that it is rapid onset. So on one day X-ray is normal, next day suddenly we will have the big consolidation. And there is rapid tearing. If there is no further hemorrhage, there will be rapid tearing within 12 hours or 24 hours. So no infection will appear so fast and clear so fast. So that's how with the serial X-ray, you can diagnose the pulmonary hemorrhage. Now we come to the mediastinum. It is a structure between two lungs bounded by anteriorly sternum, posteriorly the vertebral spine, and on both sides mediastinal pleura. So accordingly, on chest X-ray PA view, it has right and left borders. Now it can also be divided by arbitrary imaginary lines, and that's how with the lateral X-ray. Another one line is drawn imaginary anterior to the trachea and posterior to the heart. So this becomes anterior mediastinum. Second line is just about few centimeters behind the vertebral shadows. So this is the middle mediastinum, and posteriorly paravertebral area is posterior mediastinum. So these are the various structures which are seen there. We all know what are the contents. So there is some signs to locate the lesion. So one of them is cervical thoracic sign, where we see the mediastinal mark where it's located without doing a lateral chest X-ray. So you have to see the borders of the mediastinal mass. If the border, lateral border, which is along the lung, is seen going above the clavicle, that means it is burning lung X-ray, lung only, and this mass is posterior mediastinal. However, it is reaching up to the clavicle and not going up. That means it is abutting the heart, and this mass is anterior mediastinal. We'll see the examples also few. This is the patient where we can see this is the mass just reaching up to the clavicle, not going up. So it is the anterior mediastinal mass, and heart border is also not well seen. So this is the same patient. CT scan confirm that it is located in the anterior mediastinum. Now this is the another patient. You can see this mass is seen, heart border is silhouetted, and here the aortic knuckle is not seen, because aortic knuckle is also anteriorly. So this mass is touching the aortic knuckle and heart border. So this is anterior mediastinal mass. But you can see the descending thoracic aorta here, some outline, which is the posterior mediastinal structure. It is clearly seen. That means mass is not going to posterior mediastinum. It is purely anterior mediastinal. But here, just the reverse. You can see there is a mass. This is overlapping the aortic knuckle, but aortic knuckle is seen through the mass. Now aortic knuckle is anteriorly. So this mass, although overlapping the knuckle, it is not anterior. It is totally posterior mediastinal mass, because aortic knuckle is also seen and mass is also seen going above the clavicle. So with these two masses, we can differentiate it is anterior mediastinal, posterior mediastinal. Now, one should remember here that the children up to 8 to 10 years of age, particularly infant, they can have mediastinal winding like this, and this is the normal thymus. This should not be confused with any pathology. Bilateral smooth enlargement of the mediastinum is perfectly normal for young children. Now, this is the heart. We should know the mediastinal, the heart ratio. So this is how heart diameter is calculated in the midline. Higher distance the right side, higher distance left side. This is the size of the heart, and you make the ratio with the thoracic diameter. So adults normally should be up to 45%, and neonates heart is larger, it can be up to 60%. It is important to note that normal heart may also enlarge if there is supine film, it is expiratory film, or there are raised diaphragm because of any reason, as we have seen previously. This is the cardiomegaly. So cardiomegaly can be because of the enlargement of heart, or it can be because of the pericardial effusion, and on chest X-ray, you cannot differentiate that. Now come to the pleural cavity. Pleural cavity most common is pleural effusion, and mild pleural effusion, as we all know, can be seen as a blunting of the sharp, sharp CP angle, cardiophrenic angle. Very easy to diagnose. Large effusion will be seen as a opacity which is quite homogeneous. No air bronchogram. That's how we differentiate from a collapse or consolidation. And it is a curvilinear appearance like this because of the capillary action. Again, easy to diagnose. However, those appearances for the erect PA film, if the patient is lying down, what will happen? The fluid will spread in the dependent part. So it will have the increased density like this, homogeneous increase, because patient is lying down, and you get fluid effusion appearance like this, which is sometimes difficult to diagnose now because patient is supine. So increased density should also prompt you to suspect there could be pleural effusion. Now there is subpulmonary effusion, when the pleural effusion get loculated between diaphragm and lower part of the lung or pleura. It doesn't spread very fast. That will be seen as an increased height of the diaphragm and blunting of CP angle, and this is more the elevation is more on the lateral part. Laculated pleural effusion will not have a typical curvilinear appearance, but you can see multiple lines like this. Again, capillary line, curvilinear, convex, or rounded line. One we can see here, another is here, and another in lower part. So this indicates laculated pleural effusion. So tapping or drainage will be difficult if there is laculation like this. It can also get laculated into oblique fissure, as we have seen on lateral schematic diagram. Fissure will be like this from spine to anterior angle. But the fissure is actually also pleural cavity. So fluid may get laculated here obliquely, which is seen in the fissure. But on PAPM, it can be seen as homogeneous mass like this appearance. So, but there is also normal pre-pleural effusion. So you can suspect that is homogeneous opacity could also be fully pleural effusion laculated in the fissure. Pneumothorax. Pneumothorax are easy to diagnose because they contain air in the disease pleura. But if there is iatrogenic, you perform some procedure like placement of the catheter or pleural tapping, and then small pneumothorax occur. So pleura is very thin and it is difficult to diagnose on chest X-ray. You have to be very careful and carefully analyze the X-ray, preferably PA film. So this patient has venous catheter has been put, and after that you can see this apices is quite loosened on this side. You don't see these vascular markings here. So that you suspect there is a pneumothorax, and on careful analysis you can see the small line of the collapse lung here like this. Here. Hydropneumothorax, when there is air and fluid. So air fluid hallmark is you see the air fluid level. Horizontal, small or large, upper or lower line that indicates air fluid level. So if you see the air fluid level or horizontal line of the fluid, it is not simple effusion. It is always hydropneumothorax, because pleural effusion will not be straight, it will have curvilinear margins. The pleural metastasis can also be seen in cancer patients, advanced cancer. You can see multiple nodules like this. It's like a fluid density, but it has a nodular appearance, both sides, here as well as here. So these are the pleural metastases. They can be quite large and may look like a lung mass also. Now, in patient is dyspneic and they symptomatic, you tend to drain it. And if there is recurrent effusion, you need multiple drainages. You can put chest tube or more effectively the pictal catheter like this. So this patient has been put down catheter for drainage, and they can be seen in pleural cavity, and you can observe whether it is emptying or not. And when there is complete emptying, you can take the palliative procedure like pleurodesis, etc. if required. Now we'll come to the chest wall. Chest wall masses and lung masses, this is important to differentiate, and because they can look similar. So there is an angle between the lung and the mass, peripheral mass. So we can see here this obtuse angle with the lung parenchyma. So this type of obtuse angle indicates is the pleural or chest wall mass. Here is also these masses are touching the chest wall, but it has a right angle or acute angle. So we can say that these are actually lung masses which are touching the chest wall, but not primarily from the chest wall. But there can be some limitation also. Sometimes, like for example, this is a young patient, destroyed ribs and large subtissue mass. So it's a chest wall mass extend to lung, but angulation wise, you cannot say that definitely it's the lung mass or chest wall mass. But because of the rib, we can say this. You can also have the large extrathoracic, intrathoracic component, this large chest wall, sarcoma of the chest wall. Rib metastasis. This patient is a Hila lung cancer here, and you can see the chest wall mass, which has obtuse angle. So I can diagnose that this is the chest wall metastasis because this is obtuse angle, and you can also see this zoom part. This rib is missing here. The second rib is seen only this part, they're not seen. So this is the rib metastasis, which will be seen as a chest wall mass. So pay careful attention to ribs also if there is any pathology. Here is the patient myeloma. You can see multiple small lytic lesions crowding of the lips, and there is small opacity along the chest wall. This indicates either fracture or hematoma, and because of these multiple lesions and small fractures, patient will not be able to take deep inspiration, and you will get some expiratory film. So that should be accepted. You can also have calcification of the costal when the rib ends, there is a cartilaginous part which joins to the sternum. So this is called the junction of the cartilaginous and bony part. So this costochondral area junction can have dense calcification like this, which sometimes overlap on the lung field and can be seen of the masses. Here you can see in the first strip, but you can see in the old age all ribs. So this should not be confused with any pathology. If you see that it is bilateral and whatever the shape, you can see that it is normal. Now diaphragm, right diaphragm is generally higher in 90% of the patient, and in rest it can be of the same level. So the distance of more than 3 centimeter or more than 1.5 intercostal space will be called as a raised diaphragm. On the other hand, if it is this distance from the dome is less than 1.55 centimeter, it is called flattening of the diaphragm, which is generally seen in the chronic obstructive pulmonary disease or airway disease. Because of the emphysematous lung, the diaphragm will be flattened like this. Diaphragmatic palsy, the same patient with the hilar mass and rib. Here you can also see that the left diaphragm is quite high, much higher than the right diaphragm. So this is diaphragmatic palsy. This patient, you can see diaphragm. There are two actually opacities. One is here and another is here. This is also undulation. Both these the outlines are diaphragms. So these two opacities, two outlines are there because there is humps like a camelback hump, and this hump can be complete or it can be small, and this is perfectly normal and should be ignored as a finding of no significance. Diaphragm can also be raised if there is abdominal distension because of the gas, massive ascites, and both diaphragms will be raised, and that will cause cardiomegaly and crowding of the ribs like this. So that is expected. Air under the diaphragm is very easy to diagnose. Mostly it's because of the pneumoperitoneum or perforation or sometimes subdiaphragmatic abscess. So it is easy to diagnose. Another common cause is sometimes you can see this lucencies below the diaphragm because of the bowel loop, mostly the colon, which goes between the liver and diaphragm. So this is called Chilaiditi syndrome or finding. This is again of no clinical significance and can be ignored, but one should be aware of that. Now, my last two slides, I will show the post-treatment case because many of these patients will be receiving or had received some treatment. So there are some, they also produce some abnormalities or findings on chest X-ray. Drug toxicity. Many chemotherapeutic agents particularly have drug toxicity, and they mimic other complications like infection or hemorrhage or pulmonary edema. So in the right clinical setting, with the clinical correlation and other causes are excluded, you can diagnose drug toxicity. Mostly they will be seen as the ground glass opacity, just like edema or infection. But because it is a systemic condition, it will be bilateral. It may be asymmetric, but patchy or different type of ground glass opacities will be seen, and patient will be dyspneic, but there will be no fever. Again, these opacities tend to be peripheral in location and in the lung basis predominantly. For most drugs which cause pulmonary toxicity. In later stage, it will undergo fibrosis and reduction in the volume of the lung and increase in the bronchovascular marking. But acute, it is always ground glass opacity, bilateral, peripheral, and at the lung basis. Radiation also causes pneumonitis, but this occurs little late, at least 3 to 6 months later it occurs, and which is given for whatever cause. Initially, it will be seen as a ground glass opacity and then consolidation. But this consolidation is and ground glass opacity is very sharply defined. You can have the good margin, which normally you don't see on the infection, because this confirms exactly to the margins of the radiation field. And initially, there will be ground glass opacities, and subsequently, they become dense consolidation and fibrosis, and it will persist forever. Patient can also be symptomatic. A patient can also have mild fever when it's acute condition. So it is important to sometimes difficult to differentiate from infection, but the history of radiation and exactly particular that area which is confined on chest X-ray, you can diagnose it. This is a pneumonectomy patient. The right lung has been completely removed. So you see that sudden cut off of the bronchus. The residual lung is now overexpanded and more emphysematous, so black. It is also going to the mediastinal heart has all gone to this side. So this is the pneumonectomy changes. Small fluid of the thickened pleura, visceral pleura can be seen, and small fluid or air within that cavity is considered normal. Lobectomy, patient has been lobe has been removed, so we can see similar appearance. This is rib crowding because of volume loss. The lower lobe has a diaphragm has raised up to compensate for volume loss, and there is also this heart is totally on the same side, so there is mediastinal shift. So this type of appearance is in the lobectomy, and on CT scan you may also see this residual cavity containing some oozed out fluid in the pleural cavity and air. So this is like a hydropneumothorax, but this should be ignored. This does not require any treatment. It will heal by itself, and no intervention is required. Because of the severe infection or any other pathology or treatment, you can have the entirely destroyed lung. These are the extreme cases. This is the post-infection cases, both sides. You can see this mediastinal shift, truncation, deviation, lot of fibrosis, raised diaphragm. So this type of lung is almost destroyed totally on the left side, and the right lung has expanded. Here the opposite, the right lung is abnormal. Trachea is almost on the lung fields, complete heart on the right side, and there are multiple areas of cavitation which indicates bronchiectasis, damaged alveoli which are coalescing together to form thin-walled cavities, fibrosis, distortion of the anatomy. So these are the various type of abnormalities which are destroyed lung. One can be available. So that was the brief overview of normal pathology, normal anatomy, some pathological examples, and now I am ready to take any questions or discussion.
Thank you very much, Dr. Thulkar. As usual, very simple, very lucid, and everybody must have understood so many things in the basics of X-ray. So before Arun takes this, there are questions in the chat box. I just want to say to everyone, because it is not easy to remember whatever Dr. Thulkar has said just now. So this lecture and recordings are available on the IAPC website. So whenever you will be having time, or you will find the similar X-ray in future, please go ahead and see this and listen to Dr. Thulkar's lecture. So Dr. Thulkar, already 100 people have joined in the morning at 6:30. So
yes, that's good. I'm quite impressed. But I just kept it basics. So I think whatever I told, most people already knew it. So it's just like revisiting what we
no, it was only basics were required. So Arun, go ahead with the questions, please. We have time, 8 minutes.
Thank you, ma'am. Sir, first question is how to differentiate interstitial lung disease from malignancy of lung on a chest X-ray.
Yeah, interstitial lung disease, they are chronic condition. This will be seen as a bronchovascular markings, prominent bronchovascular marking. Lung malignancy, lung cancer will be seen as I see on the example, masses or effusion or consolidation. But interstitial lung disease, which can be benign, most commonly usual interstitial pneumonia or non-specific interstitial pneumonia. They are seen as increased bronchovascular marking, and these are not focal area. These are basically mostly systemic, so they will be bilateral, and so more reticulations, lines will be seen, and you can also have nodules between that. So it can be reticular or reticulonodular bilateral opacity, which is not a feature of generally malignancy. Malignancy is not bilateral most of the time.
Okay, thank you. No other question. No, rest of them are comments.
Okay, so Dr. Thulkar, lots of complimentary messages. So before we close today's lecture, I just want to announce a few things. That we are starting pharmacy course from February. This is the February 27th. The details are available on the IAPC website. We have posted it on the IAPC website. So the pharmacists or the nurses, those who are looking after your opioids storage and dispensing, kindly encourage them to join that course. And Dr. Saroja and Dr. Shobha and with Dr. Lulu, they really worked hard to make a robust curriculum. So please encourage your pharmacists to attend this course, so that they should be well versed with the NDPS Act, and they should be doing safe dispensing practices of opioids. Another announcement that this is the last lecture of the third series, and next lecture will be on just a minute. Archana has sent me the dates. Archana, what is the next?
14th February.
Sorry, thank you. So next lecture we will start from that will be fourth series, that we will start from 14th of February. And don't miss a single lecture, because in this series we are going to talk only about the drugs which we are using in day-to-day practice. And in every lecture we will be discussing only single drug. For example, in one lecture we will be discussing paracetamol, in another lecture we will be discussing only antiemetics, something like this. So and this lecture will be taken by exclusively by our JRs, and their teachers will be moderating, and we have requested our teachers, the moderators, to keep that interactive. And miss, like the take home should be as much as practical things possible. This is what we have requested to all the moderators. So thank you very much for joining in a big number. And thank you, Dr. Thulkar.
My pleasure, ma'am. I really enjoyed
in
it.
the last, you were it was difficult to speak for you also. This is because of the COVID. Everyone is having problem in the, they cannot
Yes,
speak
ma'am.
for a long time.
It's
But
really bad time.
you did it so well, and I was confident that everybody will like this lecture. And there are so many complimentary messages. And thank you, Archana, and thank you, Nisha, for keeping everybody on track. And we will all see you. Just take a break for 2 weeks, and then we will see you again in the February, and we will post the lecture and the name of the speaker on the website and all other groups.